Welcome back to Professor Dr. Muhammad Amir Memon official YouTube. Today, we will know about ventricular septal defect, VSD. But before we proceed, if you are new on my channel, please do not forget to like, share, subscribe, and hit the bell icon for instant and regular updates. Let's start. Ventricular septal defect, or VSD, is the most common congenital heart defect, accounting for about 25% of all congenital cardiac lesions. It involves an opening in the ventricular septum, most commonly in the membranous portion, though it may also occur in the muscular part. VSDs vary in size. Small or restrictive defects are usually less than 0.5 square centimeters. Moderate ones range from 0.5 to 1 square centimeter, and large or non-restrictive defects typically exceed 1 square centimeter, potentially causing significant cardiac complications. In ventricular septal defect, a left-to-right shunt develops, influenced by the defect size and the balance between systemic and pulmonary vascular resistance. This shunt typically appears after the first few weeks of life as pulmonary resistance naturally decreases. The heart compensates with biventricular hypertrophy. The right ventricle manages increased blood flow, while the left ventricle adapts to volume overload. Over time, if pulmonary pressure exceeds systemic pressure, the shunt may reverse, leading to cyanosis, a condition known as Eisenmenger physiology. Clinical findings in ventricular septal defect vary based on the size of the defect and the degree of pulmonary blood flow and pressure. Small defects may be asymptomatic, while larger defects can lead to breathlessness, poor feeding, failure to thrive, and frequent respiratory infections. In small ventricular septal defects, patients are usually asymptomatic, and the condition is often detected incidentally during routine physical examination. Both heart sounds are typically normal. A loud, harsh pansystolic murmur is usually present and best heard at the lower left sternal border, often accompanied by a palpable thrill. In newborns, the left-to-right shunt may be minimal due to higher right-sided pressures, which can delay the appearance of the murmur. As pulmonary resistance falls, the murmur becomes more evident in the following days. In moderate ventricular septal defect, a significant left-to-right shunt occurs with increased pulmonary blood flow and resistance. During infancy, affected babies may show signs of tachypnea, feeding difficulties, recurrent respiratory infections, and poor weight gain. Congestive heart failure can also develop. On examination, a systolic thrill may be present, with a normal first heart sound and a loud pulmonary component of the second sound. A loud pansystolic murmur is heard along the left sternal border. In large ventricular septal defect, there is excessive pulmonary blood flow with the development of pulmonary hypertension. Infants often present with feeding difficulties, excessive sweating, poor growth, and frequent respiratory infections. Heart failure appears early in life, and cyanosis may occur during episodes of crying. On auscultation, a loud pulmonary second sound is heard, along with a less harsh pansystolic murmur at the left sternal edge. Additionally, a mid-diastolic rumbling murmur may be heard at the apex, and an ejection systolic murmur at the pulmonary area. Chest X-ray plays a key role in the diagnosis of ventricular septal defect. In small defects, the X-ray may appear normal or show mild cardiomegaly with a slight increase in pulmonary vascular markings. However, in large defects, more prominent findings are seen, including significant cardiomegaly due to volume overload and markedly increased pulmonary vascularity, reflecting excessive pulmonary blood flow. These radiographic features support the clinical suspicion and guide further evaluation. Medical management of ventricular septal defect depends on the size of the defect. In small VSDs, parents should be reassured, as the condition is often benign. These children can lead normal lives, and the defect may close spontaneously by the age of 2 to 4 years. In infants with large VSDs, the goals are to control congestive heart failure and prevent pulmonary vascular disease. These infants often fail to thrive. Heart failure is managed with medications like digoxin, diuretics, and afterload reducers. If there's poor response to medical therapy or signs of worsening pulmonary hypertension, early surgical intervention becomes necessary. Surgical management of ventricular septal defect is crucial, especially in preventing irreversible pulmonary hypertension, which can often be avoided by repairing large defects before the age of 2. Surgical intervention is indicated in several situations. These include failure of medical management in infants with large defects, poor weight gain or failure to thrive, and signs of progressive pulmonary hypertension. Recurrent respiratory infections and persistent symptoms despite optimal medical therapy also warrant surgery. Additionally, a significant left-to-right shunt leading to volume overload or any evidence of ventricular dysfunction further justifies timely surgical closure of the defect to prevent long-term complications. Surgical intervention for ventricular septal defect is recommended under specific clinical conditions. Surgery becomes essential when congestive cardiac failure cannot be controlled despite maximum medical therapy, or if the infant fails to thrive. A child aged between 6 to 12 months showing signs of rising pulmonary hypertension also requires surgical repair. For children over 2 years old, surgery is advised if pulmonary blood flow exceeds twice the systemic flow. Additional indications include the presence of a supracrystal VSD, where there is continuity between the aortic and pulmonary valves, associated pulmonary stenosis, or the development of aortic regurgitation due to valve damage. The prognosis of ventricular septal defect largely depends on the size and location of the defect. Small VSDs generally have an excellent outlook, with 30 to 50% closing spontaneously, most often within the first year of life. The majority of these spontaneous closures occur before the child reaches 4 years of age. Children with small, hemodynamically insignificant VSDs usually lead normal, healthy lives without long-term complications. However, larger defects require closer monitoring and, often, surgical intervention to prevent complications such as pulmonary hypertension. With timely management, even large VSDs have a favorable outcome and good long-term prognosis. Ventricular septal defect can lead to several complications, especially if the defect is large and left untreated. One of the most common issues is congestive heart failure due to volume overload. Affected children may suffer from repeated respiratory infections and poor weight gain, leading to growth failure. There's also a risk of infective endocarditis, a serious infection of the heart lining. Over time, persistent increased blood flow to the lungs can cause pulmonary hypertension, which may progress to Eisenmenger syndrome, a reversal of the shunt, resulting in cyanosis. If you miss any point during today's lecture, don't worry. You can watch the full-length video anytime on my official YouTube channel.